Hey guys, welcome to chapter 11. Today we are going to be talking about, paraphilic disorders. We're going to talk about sexual dysfunction, and we're going to talk about what we consider gender dysphoria. Okay, so first we're going to talk about these paraphilic disorders. Now, I do want to note, if conversation about any of these things is triggering for anybody, feel free to fast forward through those things. You do need to know the definitions of each disorder for your exam. These disorders are interesting, but if they cause you extreme uncomfortableness or any other issues, go ahead and just make sure you know the definitions, all right? Okay, so sexual behavior, we have a wide spectrum of what people feel comfortable with, what they feel is appropriate, what they feel is, right or wrong. And these are individual feelings and opinions and all of that, right? Okay, so then how do we decide what's normal? When we evaluate the normality of given sexual behavior, the context, right? The context is very, very important. Attitudes and behaviors related to sexuality really change continuously over time and depending on what culture you live in, okay? Now, the big contemporary human sexuality researchers, these are names that you will hear often. The first one people are often familiar with, and that is Kinsey. Now, Kinsey is more popular because he did a lot of publishing. There's been movies that explain some of the research he did. Some of the research he did was very, very good, and other pieces of his research, the validity of it starts to become a little bit fuzzy. Most of it's done with self-report and a lot of other things. But Kinsey was really one of these people that put sexuality research on the map as legit science. Okay. Now, the other two people tend to work together. So usually you'll hear Masters and Johnson. So Masters and Johnson are William Masters and Virginia Johnson, and they've done an amazing amount of research on sexuality and on the phases of sexual intercourse and a lot of other things. So these are your big names, are Kinsey and then Masters and Johnson. So the first thing that we're going to talk about are paraphilic disorders, okay? Paraphilic disorders or paraphilias. These are behaviors in which an individual has recurrent, intense, strongly arousing fantasies, sexual urges, or behaviors that involve one of these things, okay? They need to involve either non-human objects, children or other non-consenting persons, or the suffering or humiliation of yourself, or the suffering of or humiliation of someone else, a partner. Okay? Psychological dependence on the target of the desire, meaning the object, the person, whatever that is, it ends up resulting in the inability to experience sexual arousal without the target. Okay, and this is where it is a disorder, right? This is not like I'm interested in this behavior. It is this disordered piece where someone is basically unable to experience sexual arousal without that object or thing going on. Okay? We are going to talk about all of these, but we're going to talk about pedophilic disorder. We're going to talk about exhibitionist disorder, voyeuristic, fetish disorder, and partialism, frauderistic disorder, and then sexual masochism and sexual sadism. And I apologize, I may cough every once in a while during this. But I'm going to power through it. Okay, and then we're also going to talk about transvestic disorder, okay? And we'll talk about how that differs from gender issues, okay? So let's start with this one. And let's be very clear, this one and others will get you arrested and put in prison. All right. Paraphilic disorder is one in which an adult is sexually aroused by children or by adolescents. This arousal is equal to or greater than the sexual arousal of being with or seeing someone who is a physically mature individual. Okay? This diagnosis includes both people who have acted upon the urges and those who have not acted upon the urges. So you can have this disorder even if you've never acted upon the urges, but you really are sexually aroused by children or adolescents. Unfortunately, 2/3 of all sexual assault victims are children and adolescents. Nearly 2/3 of those victims are female. The vast majority of perpetrators are male. About 1/3 of offenders are relatives of the victimized children. Okay? So yes, there's some very bad stuff out there. I'm not going to go into all of this, but it is important to be aware of this information. It is important to really be aware of who your children are around. It's very important to have many, many conversations with your children. They should be sick of this conversation where you just, casually talk about who they saw that day. And, I'll often asking, is anything that made you uncomfortable while being in that situation? Or, hey, while you were in that situation, did anyone ever ask you to leave the room and go with them one-on-one to spend time? Just these kind of open conversations. And of course, open conversations about, hey, so when we do bath time, you wash your private parts, but if anybody else is here, nobody else is allowed to give you a bath, or nobody else is allowed to touch those parts, and I often ask, now who again is allowed to, touch your tummy under your skin? Is grandma allowed? Is, so-and-so allowed? We sort of go through these conversations to make them just kind of a continuous conversation. So hopefully, if anything ever comes up, the child will feel comfortable mentioning it to you. They will feel comfortable talking to you about it. We always talk about, if somebody ever tells you not to tell your mommy and daddy something, then that's definitely when you want to tell us, because that's not a good thing. No one should ever ask you to keep a secret from your mommy and daddy. On and on and on. You get my point here. I'll stop. But it's really important to continuously have these kind of conversations. And most likely they will never need to use this information, but we want them to be, armed with information just in case. All right. Now, we're going to move on. And the next disorders are typically, individuals who are, I guess, victimizing adults. Okay. Exhibitionistic disorder. If you think about the exhibitionist, right? This is a person who has intense sexual urges and arousing fantasies involving exposing their genitals to a stranger. This is your flasher. Exhibitionistic disorder begins early in adulthood and tends to persist throughout life. This disorder is often comorbid with conditions like major depressive disorder and substance abuse. When I lived in San Francisco, there was a guy for a while that was living in the park across from my house, and darn it, I swear every time my mom would visit, that man had his penis out of his pants and would yell and get her attention, and she would look over. Not great. Not really what you want for a stroll in the park. But there is something that person would have exhibitionistic disorder. Okay. It can get you arrested. Now, the next one is voyeuristic. If you think of the word voyeur, so a voyeuristic disorder is an individual that has a compulsion to derive sexual gratification from observing the nudity or sexual activities of others who are unaware of being watched. Okay, this is your peeping Tom. This is your person who has a telescope and is looking in other people's windows, or is creeping up to their house and looking in their windows while someone is naked in the process of disrobing or in the process of engaging in sexual activity. Okay. Voyeurism is interesting, the most common paraphilia. And that's possibly because a lot of people can get away with it. Law officials are unlikely to apprehend individuals with this disorder. And these individuals are even less likely to seek treatment. So there's some information on that. But that's what voyeuristic disorder is. Okay, the next one is fetishistic disorder. I find that word difficult to say for some reason. People with fetishistic disorder are aroused by an object. Okay, so this is, with fetishes, they are, non-human objects. They are shoes. Well, that's not true. It's not that they're not human objects, because they can be parts of humans, but not the whole human. Anyway, they typically are things like shoes or rubber or feathers or feet and toes is a common one, or fingers, or parts of somebody's body. Okay, now to note here, arousal depends on the object rather than the sexual intimacy of being with the partner for achieving sexual gratification. And often this person gets to the point where they cannot be aroused without this object or touching of that part of the body. Now, behavior is not fetishistic when involving an object specifically designed for sexual excitement, right? So a vibrator doesn't count in this. Anything else that is intended for sexual excitement doesn't count. Here's a word that you're going to want to know, and that is partialism. Okay, with partialism, partialism is part of fetishistic disorder. For here, this is specifically that the individual is aroused by the presence of a specific body part. So partialism is that body part specific fetish. Okay. The attraction to the objects or body parts must be recurrent, they must be intense, and they have to last at least 6 months. Okay. The next one is Voyeuristic, and the word frauder means to rub. So when I think of Voyeuristic disorder or frauders, I think about the people, on a bus who rub their genitals up against you while walking by. The individual has intense sexual urges and sexually arousing fantasies of rubbing up against or fondling an unsuspecting stranger. And that has to be part of it, is that the person is unsuspecting, did not ask for it. This is a violation of human rights, right? So men with Voyeuristic disorder seek out crowded places, and they end up rubbing, their private parts against somebody else, or walking by and fondling someone's breast or other private parts. Okay. Next, we're going to talk about sexual masochism and sexual sadism. These are two different things. With sexual masochism, it's that the person seeks pleasure from being in pain. Okay, so people with sexual masochism disorder are sexually aroused by being beaten, being wounded, otherwise somehow being made to suffer. Sexual sadism is a disorder that sexual arousal is from the physical or psychological suffering of other people. Okay, now to be clear, the DSM-5 does not classify bondage, domination, sadomasochism as a disorder in itself. Okay, now little scientific research exists for both sexual sadism and sexual masochism because people with this disorder often do not seek treatment and often don't feel the need to change. So, I think that with these disorders, they can be technically disorders if they're causing problems in the person's life. Like if you need to be punched in the eye to be sexually aroused, and then every time you go into work, they wonder why you have a black eye, and that becomes a problem, then it's a problem. However, if you have two consenting adults and actual damage is not necessarily being done, and both people are 100% interested in doing this, then it's not technically a disorder because it's not causing problems in the person's life in any way. If anyone feels uncomfortable, then it shouldn't be occurring. If it's causing problems in the relationship, in your employment, in anything else, then it's a disorder. I hope that makes sense. Okay. So now we have transvestic disorder. Okay. And I want to be very clear that this is, and I put this down here, this is not the same as transgender or gender fluid or any of those other words that go along with that category of terms. Okay. This diagnosis is applied to individuals who engage in transvestic behavior and have the symptoms of a paraphilic disorder. Okay? So it refers to the behavior of dressing in the clothing of the opposite sex in order to gain sexual arousal. Okay? So the goal is sexual arousal, which again is not in any way the same as gender identity. Okay? It's only diagnosed if distress or impairment is experienced, commonly displayed in men. So I always give this example for some reason. If there's a man who works in, let's say he works fixing cars, right? And he feels this interest and need to wear ladies' underwear when he goes to work each day, right? If nobody sees it and he's not doing anything that's causing any problems and everything works out well and he just kind of enjoys it, then fine, not a disorder. If he goes to work and someone else sees that he is wearing women's underwear and it starts causing problems at work, but yet he continues to do it and feels that he cannot stop doing it and feels compelled to do it, then it's causing problems and is it therefore a disorder. If someone cannot be aroused without the clothes of the other sex, then it's a disorder, right? If we cannot be aroused without these things, then sometimes it causes problems and therefore a disorder. All right. Now, we have theories and treatment of paraphilic disorders. Biological perspectives. Now, let me be very clear with the first one here. This is when we are talking about mostly pedophilia. So with pedophilia, castration, there's two types of castration. There's medical induced castration, which can be with medication, that causes someone to be impotent, not able to gain an erection, and therefore not able to harm someone else. And then there's physical castration. Some people choose to do this. Some people have such urges to harm someone else sexually, or to engage in sexual activity with children, and they know it is wrong, but they feel that they cannot stop themselves. Some people opt for physical or medical castration. Some people can be court ordered to take medications that are basically medical castration if the idea is that this person is a danger to society otherwise. Okay? Other people use just your typical other psychotherapeutic medications, anxiety medications, antidepressants, things like that. Now, psychological perspectives, we do have group therapy. Group therapy can occur in the outpatient setting or in prison settings. We have cognitive behavioral perspectives on this, and we also do a lot of relapse prevention. Okay, and again, a lot of this stuff happens in prison settings because that's often when somebody chooses to be seen therapeutically to receive treatment for these disorders. Not very many people with these disorders seek out treatment on their own. Okay. Next, we're going to talk about sexual dysfunction. Now, this I see much more often in my office, right? I talk about sexual dysfunction. I talk about sex with clients. Well, often, very, very often. This is actually really good information to have as far as talking to people and to clients about, the different phases of sexual excitement and plateau and resolution and how that works at different periods of time in their lives, and knowing sort of female, lubrication and when it happens and how it happens differently before or after babies and all of that data. It's also important to know about, why some people have certain sexual dysfunctions at certain times. And in some ways, a lot of psychoeducation that is just educating people on these things can be really helpful and ease their minds. I often say, look, you're not broken. There's not something horribly wrong with you. But let's talk about how to make it better. All right? So, with sexual dysfunction, abnormality in individuals' sexual responsiveness and reactions. Okay? We have feelings of significant distress or impairment. It may be lifelong or acquired. It may be generalized or situational. All right. These are our first sexual disorders. We have one for men and one for women here. Male hypoactive sexual desire disorder. Okay, and I emphasize that hypo so you can think in your head about what that means, right? So this is going to be abnormally low level or no level of sexual interest or sexual, interest in sexual activities. Okay, now what we need to note is with this, it includes few or no sexual fantasies, right? This is this guy who genuinely has little to no sex drive. Often I see this occur with depression. Actually, mostly I see it occur with depression. Okay, but what it's important to talk about in the therapy setting is that it's not about whether or not he finds his partner attractive. Okay, so often the partner will start to feel like, well, maybe he's no longer attracted to me. Maybe I'm not doing the right things. Maybe I need to try out something new sexually. Maybe it's this, maybe it's that. And we need to talk about the fact that it's none of the above. Like, it's not the partner. It is this person. It's the person with this disorder. And we really do need to figure out what's going on with this particular person. Is it a testosterone issue? Is it a depression issue? You know, what's going on? Okay. Now, then we have female sexual interest and arousal disorder. Now, to be clear, we are talking about low levels, right? So female sexual interest and arousal disorder is when somebody is having low levels of interest and low levels of arousal. It's persistent or recurrent inability to attain or maintain normal physiological, right? So the physiological piece, and psychological arousal responses during sexual activity. Basically, we have lower levels of arousal, fewer erotic thoughts than before, less enjoyment of sexual activity, and less intense sensations during sexual activity. So this is typically somebody who, again, may be dealing with depression. Sometimes this is related to the partner, and we kind of need to figure this out. So sometimes you will see this in women who are angry, who are hurt, who are, you know, a lot of other things that can go into this. But all of these things go into their brain and are emotionally involved and then affect lubrication, they affect stimulation, they affect interest in sexual activity, etc., etc. And so often we talk about stressors and we talk about depression and we talk about all of those things. Okay, so both of those are low levels. Now, erectile disorder, this is obviously just for men disorder, right? For erectile disorder, a male cannot attain or maintain an erection during sexual activity that is sufficient to allow them to initiate or maintain sexual activity, okay? So even if they're able to achieve an erection, they're unable to penetrate or experience pleasure during the sexual encounter. So maybe they are able to penetrate, but it just kind of dies off after that. And this can be so stressful for couples. This can be so upsetting for couples. Again, I'll do this example in a male-female example. Okay, so the example will be a male-female partner. So the female feels like, well, maybe he is, again, not attracted to me. Maybe I'm not doing the right sexual activities for him to feel enough. And the woman tends to blame herself, right? As to where on the other side, the man is blaming himself and he's feeling insecure and he's feeling now anxious. And sometimes you have one time where there is difficulty attaining an erection. And then the next time the person is so stuck in their head on not wanting that to happen again and being so fearful about it that they overstress and don't maintain an erection. So we talk about that. We talk about anxiety. We talk about not freaking out. And we talk about all of the mental and emotional pieces that go along with it. Now, having said that, sometimes it's more of a physical thing, right? So sometimes the erectile disorder is due to age, drinking too much, you know, a lot of those kinds of issues. Now, we want to rule those things out. And so that's why they do have medications like Viagra, etc., that do help individuals with erectile disorder that's not just due to anxiety, depression, things like that. Okay. But like I said, it is really important to talk about in a therapy session typically with both individuals. When both individuals feel like there's a plan of what to do and an explanation that it's not really either of their faults, meaning it's not that either of them is not attracted to the other, it's just kind of a thing that's happening. Okay. We have female orgasmic disorder. This is a sexual dysfunction in women. A woman experiences problems having an orgasm during sexual activity. Women are more likely than men to report sexual difficulties involving subjective quality of the experience. So talking about subjectively not enjoying it as much, not feeling that into it, sometimes this disorder can be that, the female is overly stressed about things going on at home, things going on at work. They can be upset with the spouse or partner. A lot of things, again, go into this. Sometimes it's just not being comfortable with one's own body. So females tend to have an easier time, men too, have an easier time attaining, pleasure during sex, having an orgasm if they're feeling good in their own bodies, if they're feeling good about themselves in general. So there's a lot of psychological aspects that go into this. Another one is delayed ejaculation, okay? So this is a sexual dysfunction in which a man experiences problems having an orgasm during sexual activity. It's also known as inhibited male orgasm. So the delayed ejaculation causes stress within the relationship because the man will want to do this, want to have an orgasm. It becomes frustrating. It becomes where they know that they're kind of going too long and really don't know what to do. And the female at some point starts to, her lubrication starts to diminish, and then what was enjoyable then becomes unpleasant. And at some point, one of them has to just call it and say, we have got to stop having sex. And then both people kind of feel bad and uncomfortable, right? So again, when talked about and discussed openly, it's not that big of a deal. You can come up with an action plan. And you can come up with a plan that makes everybody feel fine about it until it resolves itself. But without discussion, it can actually start to really cause problems within the relationship because people start, again, feeling insecure and uncomfortable and upset. Premature ejaculation, sexual dysfunction that causes men to reach orgasm with minimal sexual stimulation before, on, or shortly after penetration, and before wishing to do so. Okay, so like within a minute, right? This causes problems with just simply satisfaction and people feeling like they are, maybe the man feeling like he's unable to perform enough to make the partner happy, and the partner feeling unsatisfied and frustrated. Again, you can come up with a plan that works for both of you, but you have to actually talk about it. There's a lot of different types of therapies that can be done for this also in order to help the man take longer before ejaculating. Okay. We have disorders involving pain, and these are female disorders typically, but they can affect both men and women. These are genitopelvic pain and penetration disorders. The individual experienced recurrent persistent genital pain before, during, or after sexual intercourse. Some people experience pain because maybe lining of women parts, I'll go with that, is thinned out because of a medication they're taking or post-pregnancy or things like that. There are specific issues that cause women to have contractions in that area, and then the man actually cannot penetrate, can physically not get in there. And so there are a lot of different issues that go along with this. There's a lot of relaxation techniques. There are medications. There are things that can really help with this. Sometimes these things happen after somebody has been traumatized in one way or another. There's lots of things that can be happening here, okay? And really you have to figure out with that particular person what's going on and then what to do about it. So here we have the biological perspectives. Erectile dysfunction, we do have medications that treat. So Viagra, Levirta, Cialis. We have hormone replacement therapy. And there seems to be application for corticosteroids and for physical therapy. We actually do things that aren't listed here. We can do biofeedback for these things. You can actually train yourself to more easily produce lubrication, more easily to relax your body, more easily to find yourself comfortable and seeking intimacy with a safe person, with an appropriate person, okay? A psychological perspective, there's something called sensate focus. Now, sensate focus is one of these treatments that is super common. And basically when we do sex therapy, there's a generic term here, sex therapy with individuals or with couples, what we do is we start off really slowly. So let me give you an example of a couple and what I would give them as homework. So maybe they have slowly moved away from each other over time and over course of a relationship. And they are no longer, well, interested in being intimate. And sometimes it's one person or the other person, and sometimes it's both people, but they want that back and they want to get back to that. They don't want to just be roommates, is what often people will say. And what we do is we start from the beginning and we say, okay, for this week, I want you to go home, and for every day, I need you to sit really close to this person. I need your bodies to touch each other, but that's all you do. You're not allowed to have sex. You're not allowed to touch genitals. You're not allowed to do any of those things. All you do is that you sit, you notice the warmth from their body coming to your body and yours to theirs. You breathe, you relax, you breathe. A lot of breathing. Okay, and then the next week they come back and they say, okay, we did that, that's great. Now, let's be clear, in real therapy, we have all sorts of other issues we're dealing with, but let's say it's just this for this example. Next week they come back, that all went fabulous. This next time we go to touching. We can do foot rubs, head rubs, shoulder rubs, but no touching of genitals, no any kind of sex, anything. Okay, they go away, that all works just lovely, blah, blah, blah. They come back the next time, they are allowed to touch genitals, but penetration is not allowed. So they are allowed to touch and caress in a intimate, loving way. This is a time where one person can guide the other person to talk about things that they like and enjoy. You're not supposed to say, I don't like that, but you're supposed to sort of guide them into ways that you do like. Blah, blah, blah. Eventually, most often couples end up having sex when you told them not to, and then they're all is fine, right? Some couples actually do what they were told and wait, and eventually when they are allowed to have penetration, then again, it is very specifically they're allowed to say what they want and what they enjoy, and communication is improved in this way also. Okay, that's generally sensate focus. That's all we have for sexual dysfunctions. Okay. All right. Now, gender dysphoria. Okay. So when we talk about gender dysphoria as a disorder, I've never really enjoyed having the way that this has been in the DSMs in the past. And now I feel like it makes more sense the way that it is explained. okay? Gender dysphoria is the distress that may accompany the incongruence between a person's experienced or expressed gender and that of a person's biological sex, okay? So it's the distress that may accompany that incongruence. Words you should know. There's a difference between gender identity and biological sex. I don't care how you feel about this issue. This is just what it is. These are the terms. You get to learn them. Gender identity is a person's inner sense of maleness or femaleness. Biological sex is the sex determined by a person's chromosomes. Now, even that is not that straightforward because, I mean, really, how many of you actually know what your chromosomes are, right? There are certain famous women who have different chromosomes than you would think they have. I won't go all into that. Sometimes I can have a whole conversation about that. I will pull myself back and just basically say biological sex is chromosomes, gender identity is that sense of maleness or femaleness. Now, transsexualism is the phenomenon in which a person has an inner feeling of belonging to the other sex, okay? I don't mean that they like kind of feel this way or kind of don't. They feel very intensely, strongly that they belong to the other sex. Some people with gender dysphoria disorder wish to live as members of the other sex, and they dress and act accordingly. Now again, it's only gender dysphoria if it's causing dysphoria or problems there, right? Emotional issues with it. Some people are very, very comfortable and have no qualms about it. Other people struggle with this and feel uncomfortable and they feel sad and they feel depressed about it and they feel like, well, darn, like life would be so much easier if I didn't feel so awful and so out of touch with being the other sex. So, to note, unlike individuals with transvestic disorder, these people do not drive sexual gratification from cross-dressing. They just feel that they belong, they're out of place in their body, they should be the other sex, okay? I do want to say this, is that these individuals do feel so strongly about it that they are willing to deal with possible medical procedures, possible ridicule from family and from other people in culture. So this is not somebody who on a whim just decides to do this. This is somebody who has struggled long enough that they are willing to make these, life changes and deal with any kind of cultural repercussions from that. Okay. Theories and treatment. So new approaches are used to emphasize a more fluid view of gender, right? So a lot of people now consider themselves non-binary or gender fluid, and that is, I mean, male and female dichotomy as far as gender identity. I think everybody's somewhere on this spectrum, right? I tend to be pretty stereotypically female in certain ways. Like, I don't know why, but I love the color pink. It makes me intensely happy. I actually really prefer the color that is Barbie pink specifically. I don't know why, but my brain tells me that color is amazing. If somebody told me I could never wear pink, I would cry. Okay? But I feel very comfortable with that. Now, having said that, I prefer pants over dresses. So maybe that moves me a few notches over on this spectrum. Blah, 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 right? people fall in different places on this spectrum. And if we see it as more of a spectrum, then we actually have people who struggle less with dealing with this gender identity that you have to be male or you have to be female. If you're somebody who doesn't get that struggle, then you're probably somebody who feels very comfortable with this being, that you are female and you feel very comfortable being female, or you are male and you feel very comfortable being male. And so you kind of don't get the other stuff. Now, excuse me here. New DSM-5 terminology reflects a theoretical perspective that doesn't focus specifically on what's wrong with the people whose self-identification differs from their biological characteristics or social roles. And that is different from in the past, okay? It's not what's wrong with them. It's the dysphoria that may come along with it that we're focused on. New therapeutic approaches really encourage clients to create their own gender identities. Okay? So again, it's not that there's something wrong with you. It's that, you're just, this mode doesn't feel right. So let's find something that does. And then let's figure out how to make that work for you. It seems to result in an improved sense of well-being. We'll just briefly go through this. We have these, standards of care for treatment for gender identity disorders. Competence, you need to know what you're talking about with actual specific data if you're going to work with somebody who has one of these issues, right? Your job is not to talk them out of it. Your job is to help them deal with the dysphoria, and that helping them deal with this dysphoria and sort of creating their own gender identities may make them end up deciding that they are comfortable with themselves as they are, and it may make them really feel that they, not make them feel, but help them realize that they really feel that they belong as the other gender. So, but they have to come up with this themselves. You're just helping them feel more confident, more competent, more solid in who they are as a person. Okay. Now, these things we won't really go into too much, but people can go through hormone therapies. We do have these options here in Alabama. People can go through M to F, or male to female chest surgery, male to female breast surgery. Excuse me, female to male, F to M, female to male chest surgery, M to F, breast surgery. And people can have genital reconstructive surgery. Some people do, some people don't. It really depends on what they want to do. It also costs a lot of money. It is a big, serious surgery, okay? So again, you don't just decide one day. And in order to have these things done, you have to see a psychologist. You have to have evaluations done to make sure that this is something for a very long time you have wanted intensely. It's not just a phase you're going through, right? Okay, biological perspective. Clinicians are increasingly developing models that incorporate integrated treatments. Goodness gracious. The big changes reflect that expansion of empirical approaches. Good thing we're on the last slide, right? To sexual disorders, adoption of a broader, more inclusive and sociocultural sensitive approach to understanding and to treatment. Okay. Now, thank you for bearing with me with my coughing and all of this nonsense. Hopefully the things I said made sense. Hopefully I said everything the right way. I am always worried. Not always worried. That's not right. I worry sometimes about saying things somewhat the wrong way, or them coming out the wrong way, or maybe I'm making a facial expression that would demonstrate more how what I mean with this. But anyway, do know that I have the best intentions with all of the things I'm saying, and therefore hear it that way. All right. Okay. I will stop talking now. I am going to go get a drink of water. I will see you in the next chapter.